Hi guys, I hope you are doing good. I will be starting my session in 1 minute. Ask anyone to join. All right. Okay. All right, guys, I'm starting this session. Do you guys have any questions for me before I begin? No? All right, okay. Today we will be doing random pharmacology questions. So let us start. All right. Serum beta hydroxybutyrate is normal and HbA1c is 14%. The patient is admitted for IV and insulin infusion. The next day, symptoms and blood glucose significantly improve. In preparation for discharge, the insulin infusion is changed to a subcutaneous regimen and mimics a physiological pattern of insulin release. The patient's insulin therapy was most likely transitioned to which of the following regimens? Okay, so we have a patient who comes in because of progressive weakness and lethargy. Over the past 3 months, he's had excessive thirst, urination. All right. So basically, he has type 2 DM. His blood pressure is okay. Pulse is a little erratic. He has dry mucous membranes. Okay, blood glucose is very high. So what do you do? Anyone? Hello, guys. Am I audible to you?
Yes, ma'am.
Okay.
Yes, I am reading because of the text is very small. Explanation.
Wait, let me just. Is it okay?
Yes, thank you.
All right. What's happening? Why is the insulin regimen changed? Anyone? What's happening, guys? What do you mean by diabetic ketoacidosis?
Diabetes type 1.
It was a medical emergency.
All right, so what do you do?
D, you take the basal insulin, insulin glargine, and then insulin lispro before each meal, short acting.
Yes,
Okay.
because of postprandial glucose is not controlled, and the postprandial glucose for that we have to add the lispro. What is it? Yes, HbA1c very high, 18, 14, sorry. Glucose significantly improve.
All right, so the answer is
D.
E.
No, D.
D, ma'am.
Okay.
Denmark.
All right. Okay. Got it. So this pharmacokinetic is very, very important for you. They love to ask you this. So this is aspartate, lispro-glucosamine. They don't ask you about glucine, but they do ask about aspartate and lispro. These are, we know that they are, fast-acting insulin, and then we have regular, then you have NPH. And then you have detrimer and glargine. The action is totally different. These are long acting, and this is instant acting. This is regular. Can anybody give me an example of NPH?
NPH
Anybody?
we are using in Pakistan like NPH 70/30. There is a 70% long acting and 30% is regular. And this is the basal insulin, but it's as compared to the glargine is short acting. A peak is
Very good.
4 to 6 hours, and the maximum 10 to 12 hours. Now the duration of
Very
the
good.
insulin.
So NPH basically stands for neutral protamine hagedon, right? It's also known as isophane insulin. In Pakistan, there are a lot of brand names such as Jubilant and Novolin and sometimes Novolin NPH. They won't ask you, but in terms of information purposes, I want you to know what that is. And then we have detrimer and glargine. So NPH is intermediate acting, glargine is long acting insulin. You should be kind of familiar with when are they acting, when are they not acting. So rapid acting insulin such as lispro and aspartate, because they are rapid in onset, they're also very short lived, and you give those in patients who are having postprandial insulin surges in response to meals. Again, they peak and they're cleared quickly, so they're given multiple times daily. Just before each meal you have to take a rapid acting insulin. Again, sometimes the patient gets really bothered by these rapid acting insulins because they have to take it a lot of times in the day. Every time they eat a meal, before that they have to take this rapid acting insulin. So people resort to long acting insulins, but again, the efficacy of rapid acting insulin is greater than the long acting insulin. Long acting insulins are again given to kind of hold it at a steady level. And again, they have little or no peak effect. They are typically given in patients once daily to control fasting hyperglycemia. So, even after fasting, that they are having hyperglycemia, usually long acting insulins are as a solution for that. So, insulin glargine, once daily plus insulin lispro before each meal, even after doing everything, you cannot control the insulin levels. Then what you do is this initially insulin lispro is given to every patient before each meal, and then kind of we navigate from there that if we need to adjust to certain medication regimens. Because with insulin, the thing is, if you also have to see if there are other medications the patient is taking. And sometimes rapid acting insulin are not given to patients if they're taking certain medication. And that is why kind of long acting insulin are preferred. So initially we always start with fast acting insulin before each meal along with any other insulin. We start off with that, and then we make further modifications as we kind of treat the patient. All right. Okay. Next question. Doppler ultrasonography reveals a femoral popliteal venous thrombosis when the patient is given anticoagulation with rivaroxaban. Okay. Compared to vitamin K antagonists, the patient's treatment is most likely to have which of the following benefits? All right. So we know that the patient is already having, kind of DBT, and what is the benefit of rivaroxaban over vitamin K antagonist?
Rivaroxaban, it's I think a factor 10 A inhibitor. It's uh, as compared to vitamin K. mm,
Vitamin K antagonist mean warfarin, no?
I think it has a better
Yes.
compliance
Yes.
because it's oral. It doesn't the INR before you give it, and can be given Q12 hourly.
Less variability in the therapeutic effect.
Yes, because in
Yes. So
vitamin K we have reloading dose and uh, less risk of thrombocytopenia. Thrombocytopenia it's happened due to the heparin. That's why now it's only block the factor 10A. Greater efficacy? No, it's not benefit. I I think E, better patient compliance. Vitamin K we can also warfarin also the oral and I think so.
All right, we all agree with E.
Yes, yes.
All right. Okay. Yeah, so what is happening that DOACs, again, we also already discussed this, kind of difference between when we were studying hematology module. So for DOACs, greater than one daily dose is required for warfarin once daily. The other thing is that DOACs have, almost very less drug interactions, but with warfarin we have to worry about a lot of other things. We have to also monitor the INR. Other thing I wanted to mention that if there is kidney failure, then you kind of DOACs are contraindicated in a lot of kidney patients. Sometimes warfarin is also kind of contraindicated in kidney patients. But overall, we use DOACs because they have faster time to achieve the effect. They have rapid onset of action. They have predictable pharmacokinetics as well. And yeah, so a lot of things are happening. But remember that, kidney problems, DOACs and warfarin, they both have an effect and they can exacerbate kidney problems. Okay. So they're still given in caution. Okay.
And
Again,
I
let's
think there is also, sorry for interruption, there is also the one disadvantage of this factor 10. There is no what you say the antagonist for as we can warfarin we can revert the effect by FFP or with vitamin K in PCC, but for rivaroxaban there is no any medication that can reverse the. This is the only drawback. Otherwise, it's more convenient for the patient. Less monitoring because it's only affect the factor 10. No need to monitor APTT or INR and other coagulation factor. Not affect on the platelets. You know. What is
Yeah, you're right. All right. Next question. Okay. She has 700 ml of urine return when a urinary catheter is placed. ECG reveals sign of tachycardia and a QRS duration of 130. Which of the following is most likely cause of the patient's symptoms? All right. Blood pressure is 90/50. Pulse is 130. The patient is sedated and disoriented. Temperature is high. So basically, a 17-year-old girl is brought to the ED after she was observed having a seizure. She has no seizure disorder history of depression and substance abuse. She was released from a psychiatric hospital. All right. So temperature is high, blood pressure is low, pulse is high. She's sedated, pupils are dilated. All right. 700 ml of urine returned when a urinary catheter is placed. Tachycardia, QRS. What's happening? What happened? What did she overdose on? It's very easy. Very easy. What did she overdose on?
Opioid.
maybe
Okay.
tricyclic?
Cocaine overdose.
No, cocaine
Yeah,
is
it's
high blood pressure. In
Because
cocaine, there is a
pupils are dilated. Yeah,
Opioid.
are dilated. So cocaine overdose should be there.
no, but in cocaine overdose, there will be high blood pressure,
High blood
tachycardia.
pressure.
Yes. I think it's a
Should be
TCA.
tricyclic
Yeah.
antidepressants.
Yeah, TCM because
So,
pupils are
have
dilated.
you forgotten the 3 C's of TCAs?
Yeah, convulsion, coma, and cardiologic side effects.
Cardiotoxicity, right? TCAs prolong the QRS interval. They also, TCAs, sometimes, some TCAs, some of the other antipsychotics, they also have anticholinergic properties, right? And those anticholinergic properties, because of that, you see that when you see that the bladder, what has happened to the bladder because of an anticholinergic activity? It's not able to contract. And when it's not able to contract, and that is why you see that the void volume is 700 ml, right? So again, if you kind of go down and you see anticholinergic toxicity, And whenever you see that, dilated pupils, hyperthermia, tachy, decreased bowel sounds, and urinary retention, think of anticholinergic. They love to ask you in terms of anticholinergic activity in TCAs and certain antipsychotics. So antipsychotics, TCAs, and sometimes one more anti-epileptics. Those three sometimes can cause anticholinergic toxicity as well. So remember that. And again, we talked about the three C's. They have QRS widening, coma convulsions, and cardiotoxicity. How do you reverse TCA overdose? Anybody?
This bicarbonate, because it's also acting on the sodium channel, we can maximum then occupied the sodium channel by bicarbonate, by hyperventilation. Also, increase the means the pH as alkalotic state. There will be less free drug.
Very good. What other thing we try to use sodium bicarbonate?
And aspirin overdose also there's also toxic. Then we also can use the sodium bicarbonate.
Very good. But remember that those two mechanisms are different. All right, the
Yes.
mechanisms are totally different. All right.
In aspirin overdose, there is increase pH of the urine, and then drug will be more polar and less reabsorption in the kidney nephrons. There are other mechanism.
What does this patient have? She had HIV infection. What did she develop? What is this? Fluffy cotton wool. What is this? What is this?
Hypertensive retinopathy, maybe?
No, the patient had HIV and she has been non-compliant. Her CD4 count is, 37. It's lesser than 50, which
Is
means
cytomegalovirus?
Cytomegalovirus.
Yes.
cytomegalovirus. What is CMV cause?
Um, and antiviral ganciclovir.
It
or
should be acyclovir or
ganciclovir.
ganciclovir most probably.
Ganciclovir.
We have matched,
Cytomegalo.
Yeah.
E.
Yes.
Yeah.
Ganciclovir for the CMV.
What's happening is the HIV severely immunocompromised. That is why I said lesser than 50 is a CD4 count, severely immunocompromised. You have greater chances of contracting CMV. Like I said, yellow fluffy lesions. That's very characteristic of CMV retinitis. You can also see sometimes retinal hemorrhage, yellow, white, fluffy retinal lesions. Jancy clover is given in any sort of CMV. Give Jancy clover. If not Jancy clover, then fornasacnid. You give fornasacnid, but that's not present over here, so you don't need to worry about it. Sometimes patients have allergy to Jancy clover, so you give fornasacnid. Otherwise, treatment is just with Jancy clover. All right. Okay. Next question. What is wrong in the labs? Anybody?
Hypotassium.
Hyperkalemia.
Hyperkalemia. Yeah.
Calcium
Yes,
normal,
hyperkalemia
normal.
5.7. Calcium
Everything
slightly
normal.
high.
And
You
yeah.
can see in most of the it's normal. If 10, if more than 12, then we can hypercalcemia. Glucose also okay. Creatinine also borderline.
Only
It's
hyperkalemia.
hyperkalemia.
Yes, hyperkalemia.
So a woman is brought because of lethargy and confusion. She has had AFib and CHF and multiple medications. So multiple medications is always a trigger. Remember that. Okay. All right. Then today she had 3 episodes of vomiting. All right. She has vision difficulties. Multiple medications. All right. Potassium is very high. ECG shows junctional escape at a rate of 48. Like I said, whenever potassium goes wibbly wobbly, the heart goes wibbly wobbly. Remember that. Even if the potassium is low, the potassium is high, you are always concerned with arrhythmias. All right. It's always going to affect the heart. Remember that. So if you kind of come down and they're asking, okay, increase of blood levels, so which of the following medication is responsible for her symptoms? All right. What is causing hyperkalemia?
Only
I
the
think
Spironolactone.
digoxin,
spironolactone caused the
Spironolactone is potassium sparing. That's why. Yeah.
hypertension.
spironolactone, but no, the vision only their problem with the vision. If they is showing the yellowish discoloration in the vision, then we go for a digoxin toxicity.
Digoxin, yeah. Then we go with
Yeah.
the
Yes, and he's telling
With the eye.
only nausea, vomiting also caused in
Mhm.
digoxin
Yeah,
toxicity.
vision difficulties,
vision
digoxin.
difficulties are there.
Yeah,
So it will
Yes.
be digoxin.
digoxin, yeah.
Mhm.
And one more thing I'd
Digoxin.
like to say. One more thing I'll
Mhm.
point out at. What is
Uh,
this?
Patient had persistent atrial fib and congestive heart
Heart
failure.
failure on multiple medications.
Congestive heart failure patient is already
Yes.
have, so the
Yeah.
patient is on the
And
medication.
heart rate also low,
Yeah.
48
Mm.
means that is other effect of the digoxin, by parasympathetic through vagus, it causes bradycardia.
Very
Yes.
good,
Mhm.
very good. I remember hyperkalemia, along with any vision problems, is always going to be digoxin. All right. So hyperkalemia with digoxin always going to be hyperkalemia with vision problems is always going to be digoxin. Remember that it's usually in a patient with AFib and CHF, they put the patient on digoxin. How do you treat digoxin overdose? Anybody?
There is what say the antibodies, the
Beta blockers.
MAP. Yes.
Magnesium.
No. There
Yeah,
is
magnesium is
specific.
one of it. Good, good, good. What else?
Yes. Mm, hyperkalemia also, if we can treat with insulin also, but specifically if we treat, there is a specific mono antibodies,
Yeah,
uh,
you're right. So we
mm.
give DigiFab. DigiFab is known as
Digifab. Yes, Digifab.
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 Digifab, yeah.
Give DigiFab. It is redoxin immune fab. All right. So what we're doing is that it will rapidly reverse the effects of digoxin, specifically if the heart is having irregular heartbeats or the patient has severe hyperkalemia. Again, the other thing is that you always hydrate the patient. All right, hydrate the patient. You do electrolyte management. Now, the thing about potassium is that potassium is not gonna, do a shit show with the heart. It's also gonna affect the kidneys, right? So it can cause acute kidney injury as well. So you immediately give DigiFab. The other medications will be magnesium will be one of them. Okay, but it's usually given if there's any ventricular arrhythmia. Over here, you see that they have ventricular arrhythmia going on, right? So you will give magnesium along with digifab over there. Again, you need to monitor the patient. You need to use it ASAP in order to reverse it. Otherwise, the damages will be significant. Okay. So remember, vision with hyperkalemia, always digoxin toxicity. How are you going to reverse it with digifab and magnesium? So magnesium, why? Because any sort of ventricular arrhythmias, they require magnesium also. Remember that you also need to hydrate the patient. Watch out for acute kidney injuries as well, because potassium is also toxic to the kidneys. So remember that. Okay. Next question. All right. Okay. So BP is high. All right. ECG shows bradycardia, PR interval prolongation. Okay. What drugs cause PR interval prolongation?
That was effect on the AV node.
Yeah.
And
Partial.
yes,
What drugs are prolonging?
beta
Beta
blockers,
beta
calcium
blocker.
channel blockers.
Beta
Beta
blocker, calcium channel blocker, yeah.
Yes,
What else?
non-dihydropyridine
Hmm.
and
metoprolol.
yeah, metoprolol as beta
Yeah,
blocker.
beta blockers.
Nifedipine is the
Mhm.
no, this is for blood pressure.
Yeah.
Sotalol also class 2 and class 4 antiarrhythmic.
Mm-hmm.
Verapamil. We have to check the history
Protalol
of the
causes
patient.
the QT interval prolongation, and
Yes,
it is the PR interval prolongation, so it will be metoprolol.
yeah.
Mm-hmm.
All right. So the
Mm.
thing is that certain beta blockers like metoprolol, propranolol, atenolol, they all will cause, PR interval prolongation. Certain CCBs can also cause, a prolonged PR interval. Digoxin, did you guys forget about digoxin? We already talked about it. Digoxin also causes PR interval prolongation. Certain antidepressants such as amitriptyline, we forgot about amitriptyline as well. And certain antiarrhythmics like quinidine, sometimes antifungals, ketoconazole. We forgot about ketoconazole. They also cause, PR interval prolongation. All right. So what will be the answer over here?
C.
B. B.
Are you sure metoprolol?
Yep.
Lusartan.
Question is
That is why I said, are you sure? Okay, like I said, CCBs, I gave you the answer. CCBs also cause PR interval prolongation. Over here, nifedipine is going to cause PR interval prolongation. Dihydroproteins such as amlodipine, felodipine, nifedipine, verapamil, diltiazem also cause PR interval prolongation. But over here that we talked about
Very strange, ma'am. Nifedipine most of the time is like reflects little bit tachycardia. But I because due to of the vasodilatation,
yeah.
it should be increased heart rate. It's
yeah
heart
that
rate
they're
also there
asking
is
what
55.
will be the question. Please read the last. The question is asking that
Okay.
lowering the
But
blood pressure.
low, yes. Yeah. We will properly. Yes.
Okay, so we CCBs inhibit the L-type calcium channel vascular smooth muscles. We know the dihydropyridines like nifedipine, amlodipine, they affect the peripheral arteries and cause vasodilation, and that is why one of the side effects for dihydropyridine CCBs is edema. Right, that's edema. Non-hydropyridines such as verapamil, diltiazem, they affect the myocardium and they cause bradycardia, slow AV conduction. And that is why it makes sense because they are type 4 antiarrhythmics. Now, why are we giving antiarrhythmics? Because they're going to lower the heart rate. So it automatically makes sense that verapamil and diltiazem will decrease the heart rate, right? And dihydropyridines do it by vasodilation. And if you kind of go up, what are the side effects for dihydropyridine aside edema? What else?
Constipation.
Constipation, okay. What else?
Verapamil can cause hyperprolactinemia.
No, I asked about dihydropyridines.
Oh,
Maybe the reflex
wow.
tachycardia.
Low blood pressure.
Headache.
Yes.
Low blood pressure is one of them.
Yes.
Very good. Hypotension, because there is vasodilation, it can cause hypotension. All right. Again, whatever is the adverse effect will be the opposite of what's happening, right? So it's dizziness, it can be flushing, it can be headache, swelling in the limbs, it can be edema as well. It causes severely low blood pressure as well, which can lead to the patient fainting as well. So you need to monitor if you're giving dihydropyridines with caution because their side effects can cause hypotension, and it can be kind of problematic for the patient. So you need to do that as well. It can cause a reflex tachycardia in response to peripheral vasodilation, and see that is why I said it is used very careful in hypertensive patients with resting bradycardia. It's especially useful over there as well. All right, okay. Next question. The apical impulse is strong while it's supine. The patient has a soft crescendo, decrescendo systolic murmur at the apex and left sternal border. All right, it becomes quite pronounced when he stands. Okay, what type of murmur are they talking about? What type of murmur is this?
Aortic.
Systolic murmur.
Yes.
Stenosis.
Systolic, yes. Where it is stenotic lesion, if the left side the border, most probably this pulmonary valve stenosis.
Okay, what type of medications should he avoid?
Patient that decrease the SVR, we have to avoid, especially the nitrates. Here, isosorbate nitrate.
Yeah, it's C.
So the patient had hypertrophic cardiomyopathy. All right, aortic stenosis. How did you guys? Did you remember? I told you guys that about this, and I told you guys that the aortic stenosis murmur is kind of similar to hypertrophic cardiomyopathy. The only way you can differentiate clinically is because of this. All right. For first is the pulses. They will give you a patient with weak pulses in aortic stenosis. If the pulses are, strong, and the heart is beating in good rhythm. See, the pulses are strong over here. The pulse is 70. The pulse is strong, right? And if it would have been aortic stenosis, the pulses would have been weak. All right, they would have been delayed. So that means that we're not talking about aortic stenosis, but it was crescendo decrescendo. Okay, if it's not aortic stenosis, it can be hypertrophic cardiomyopathy. Why are we avoiding hypertrophic? Why are we avoiding dinitrates in hypertrophic cardiomyopathy? Why? Anybody?
Because it will decrease the SVR, and in stenotic lesion we have to maintain the SVR, means systemic vascular resistance or peripheral vascular resistance. It would decrease, because it only helpful when there is regurgitation, but in
Yeah.
stenotic lesion we have to maintain the SVR.
So we know that the murmur worsens with decreased left ventricular blood volume. Therefore, medications which decrease the preload, afterload, or both are avoided. Sometimes ACE inhibitors are also avoided. What is the treatment for hypertrophic cardiomyopathy? What do you give in Holcomb?
Beta blockers also,
Beta
and
blockers.
Beta
yes,
blockers.
decrease the contractility,
Very
and
Yeah.
yes,
Diuretics are contraindicated. Yeah.
Very good, very good. You give beta blockers. What about dilated cardiomyopathy? What do you give in that?
there we have
Would you
to
give
increase the
nitrates?
contractility. Then we can give their milrinone, and we can give digoxin.
Digoxin.
So
Yeah.
And
primarily for dilated cardiomyopathy, you give ACE inhibitors.
and
So
ACE inhibitors, yeah. But
you
there is two aims. First, we have to increase the contractility and decrease the SVR
USMLE
in
wants
dilated cardiomyopathy. Yes.
I understand, but USMLE only wants you to know ACE inhibitors in relation to dilated cardiomyopathy. They're not going to ask you about that. The contractility portion. So make your life easier. Try to remember things which they are going to ask you in the exam. All right. So dilated cardiomyopathy, ACE, but yes, you're right. We do that, but in terms of step one, they don't want us to know that. So we won't know that. All right. Okay. Next question. Cardiac examination reveals an irregular tachycardia. ECG shows AFib. Right lower extremity ultrasound reveals an arterial embolus. IV heparin is initiated, and medication is most likely to cause which of the following coagulation changes? All right. So there is this man who's got to the ED. There is right lower extremity pain. Okay. Absent distal pulses. Okay. Irregular tachy, AFib. What happened? Guys, what happened?
The
Why did-
AFib drove a clot in that probably ended up
Yes.
causing arterial embolism.
All right. Why did the patient have AFib? Why? Why?
There is
It is
AFib, that's why it's irregular tachycardia, atrial fibrillation, and it could be due to hyperthyroidism or some ischemic changes or mitral stenosis. Mm, any reason, can then affect the dilatation of means the
Left atrium.
left atrium. It proceeds with atrial fibrillation. But now, due to fibrillation, he definitely the embolism. The right leg color is pale and no distal pulse. But here they ask the heparin effect. What will they if they start the heparin? Heparin is affecting through yes antithrombin 3, and what will be the effect then?
So heparin is not helpful.
Yeah.
What is the answer?
because if heparin causes the prothrombin time prolongation as well as the partial thromboplastin time prolongation too. It inhibits the factor 10A.
10
Yeah.
high doses
So-
is also affect the
so
factor
it
10.
Answer will be A, meaning ke,
no, it causes heparin causes the thrombin time
It
Heparin is
and the
actually
not
partial
the
thromboplastin time both
Sorry, sir. Yeah.
increased. Both
not the
Guys,
thrombin.
they
thrombin
asking about
time.
the activity of the factor 10, not
10A
the.
activity will be inhibited or means
Yes.
decreased.
Yeah, and
Hmm.
prolonged
So
partial thromboplastin time, not the thrombin time.
Yes, PTT,
partial
PT
thromboplastin.
only
and
will be
Yeah.
prolonged, not
Increase
the
and
PT.
PT will not
A.
change.
I go for A.
Yeah, A.
A.
E.
E.
Hmm.
Yeah, you're right. It's
Mhm.
so again, intrinsic extrinsic pathway, you need to be very familiar about that. We've already talked about it in great detail in my previous lectures. I won't go through it again. So we know that heparin, it exerts its effect indirectly by binding to antithrombin 3. What it does is it irreversibly neutralizes clotting factors. We need to be aware of that. Yeah, we need to be aware of that. It can cause prolonged thrombin time. It can also cause prolonged PDT because we know that PTINR, it affects warfarin, and PTT affects heparin. And it will also cause the decrease in the activity of factor 10A. Why? Because it has the activity against factor 10A. Anti-factor 10A is usually monitored to determine which adequate anticoagulation is achieved. The other thing about is that arterial, so this was an arterial embolus, right? And that is why there were the 6 P's, right? Pale, pulseless, poikilothermia, and what are the remaining 3 P's? Absent pulses. What are the remaining? Pallor. What else?
Poikilothermia, pulselessness, pallor,
Yeah.
and
Paresthesia.
Yeah, very good. Yeah, so again, pain, pallor, pulselessness, paresthesia, paralysis, and poikilothermia, right? Those are the 6 P's of any acute limb ischemia because of an arterial embolus, and that arterial embolus caused an atrial fibrillation, right? And that is why we gave heparin. And so basically, they were asking us about the heparin effects, but you'll also be aware about arterial insufficiency. What USMLE wants you to be aware of 3 types of things: arterial insufficiency, venous insufficiency, and neuropathic pain. And how to differentiate from all of those 3 from one another is also really high yield in terms of USMLE step 1. All right, okay. Next question. He's prescribed nitroglycerin to take as needed with chest pain occurs. The drug most likely to relieve the patient's symptoms by causing which of the following? It's really easy. What does nitroglycerin do? Very easy.
Decrease the preload.
Venodilator. It's a
Preload, yes.
venodilator. So it decreases the end diastolic volume because it reduces the
Yeah.
preload. And preload is directly related to end diastolic volume.
B, yes.
Yeah. So we know about that nitroglycerins, they are notorious for reducing the preload, and that is why they reduce the pressure on the heart. It already makes sense, right? If the heart is not functioning properly and you're loading the heart to pump more blood, so of course the heart is going to get fatigued, right? So in order to avoid that, you decrease the volume returning to the blood, you decrease the preload so that the heart can get some rest. And nitroglycerin functions on that mechanism. It decreases preload. The preload is decreased, it's going to cause decrease in the left ventricular end diastolic volume. Of course, it makes sense that because the preload was decreased, and that is why there is left ventricular EDB decrease. All right. Next question. Coronary angiography reveals no atherosclerotic stenosis, but the administration of acetylcholine elicits similar pain to ECG changes. Okay. Which of the following best explains the coronary intervention finding in this patient? Okay, so there is this woman who comes, because of occasional chest discomfort over the past year. She describes the pain as a midline pressure or squeezing sensation. All right, so, a lot of things are done, and, she was found to have a STEMI. There's no atherosclerotic stenosis, but acetylcholine is a similar chest pain. What's happening? Very easy.
Prismatal, this angina.
Could be.
And
Vasospastic angina is
yes,
there.
vasospastic angina.
Because the
Prismatal,
SP segment elevation. So it
Yes.
is because of endothelial dysfunctioning.
Yes.
Mhm.
B.
Very good. What is the treatment for vasospastic angina?
Calcium channel blockers.
Very good. CCB.
Treat with calcium channel blockers.
Very good.
And, Mhm.
All right. So blood pressure in the emergency department is 140/80. All right, pulse is okay. The heart has a regulated rhythm. Palpable pulses. Which of the following mostly causes the patient's muscular symptoms? All right, so let's see what happens. Muscle weakness, cramping, severe enough to disrupt his sleep. Exercises daily, but has had to suspend his regimen. Hypertension, chlorothalidone, amlodipine. Very easy. What happened?
Muscular pain is because of hypokalemia. They are asking about the patient's muscular
Yes,
symptoms. So the muscle
hyperkalemia can
cramps
cause
is
Hypokalemia.
cause of the hypokalemia
Mhm,
because the hypocalcemia,
because
glycemia cause.
diuretics also there. You know,
Yeah.
All right. B or D?
D.
D.
D में.
Very good. Thiazide, TZD, diuretics. We know that there are known for hypokalemia and metabolic alkalosis. And, we know that hypokalemia causes muscle weakness, cramping, and possible rhabdomyolysis as well. They are also, and, it's kind of interesting because even if you remember, I said that if it's hypokalemia or hyperkalemia, it's both of the ways. Potassium is going to disrupt the heart as well. And see over here, it's causing muscle weakness. What is heart? It's a muscle, right? So it's also going to cause weakness of the heart, which can in turn, kind of trigger certain arrhythmias. So hypokalemia and hyperkalemia both can cause arrhythmias. Remember that.
Yeah, but when there was the diuretics chlorothalidis, it caused the hyperkalemia because of absorption of the calcium. That's why there is no chance of hypocalcemia.
Yeah. All right. Next question. The patient is prescribed a medication that is metabolized, to S-nitrosultiols in the vascular smooth muscle cells and reports rapid and significant symptom relief. Which of the following components of the cardiovascular symptom is most susceptible to the medication prescribed to the patient's prescribed to his patient? All right. So we have a pain who has. So we have a patient who has 6-month history of chest tightness when he's climbing up the hill, radiates to his throat. All right, hypertension, type 2. Father had a cabbage, mother suffered a stroke. No murmur, no additional sounds. Okay, what is the answer? Very easy.
It's the nitrates, and the nitrates affects over the veins because it is metabolized to
This nitrates,
nitrosotiols.
yeah, that's
They're
just this
venodilators.
veins,
I just want you to know
venodilators.
this. See,
C,
they're
yes.
venodilators. All right. People pick arteries. Remember that they don't affect arteries; they affect the veins. They're venodilators. All right. Examination shows suprapubic tenderness. Urine analysis reveals many bacteria. All right. Okay. So women, dysuria, urinary frequency after having sexual intercourse. Very easy. What has happened?
UTI.
It's a UTI. Very good. But how do you treat UTIs? How do you treat lower UTIs? Is it uncomplicated or complicated UTI?
Lower uncomplicated. It's mostly young
Uncomplicated, yeah.
patient. It saprophyticus.
Uncomplicated.
Yes,
Very
in
good. How do you treat?
Metro.
E.
Trimethorphan,
E.
sulfamethoxazole, yeah.
Yes, yes. Uncomplicated wise.
Uncomplicated.
It's simple cystitis, recurrent intercourse can cause that. What is the treatment for those patients who are having recurrent UTIs? Anyone? So those
But
patients who are having recurrent UTIs, the treatment.
Amenity would be.
Okay, so the treatment is prophylaxis nitrofurantoin. So what you do is for those women who are having repeated UTIs, so what is advised is that after every sexual intercourse, they're asked to take prophylactic nitrofurantoin so that they don't develop a UTI. All right. So remember that as well in terms of that. Again, it was an uncomplicated UTI. Why? How do you differentiate complicated and uncomplicated based on this? All right. So the patient had no fever, blood pressure normal, everything else is normal, the vitals are normal, and that is how we differentiate between complicated and uncomplicated, right? Complicated UTI means the patient has either gone into sepsis or it is kind of progressed into pyelonephritis. All right. So this is an uncomplicated UTIs. You either give TMP, SMX, or sometimes you give nitrofurantoin as well. This wasn't mentioned. You don't give azithro, you don't give doxy, fluconazole, no, metronidazole. Okay. What conditions do you give metronidazole in? Very easy. Come on.
Amoebiasis when there is.
Trichomoniasis.
What
So, ga-
Clostridium
for
infections.
giardiasis and for
Yes.
trichomoniasis.
Protozoal there is infection also. And
Right.
there is one is the liver, abscess also cause proteasis.
Amoebiasis.
Amoebic liver abscess, right? Amoebiasis.
Yes, amoebiasis, especially they cause the liver
Mhm.
abscess and all that.
All right, guys. So for metronidazole, remember the get gap mnemonic. All right. So for G, you have giardiasis. E, you have entamoeba histolytica. T, trichomoniasis vaginalis. And then G, you have Gardnerella vaginalis. A is for anaerobes, and P is for H. pylori. All right. Get gap. All of these, giardiasis, amoebiasis, trichomoniasis vaginalis, Gardnerella, anaerobes such as bacteriocytes, C. difficile. You also give metronidazole and C. difficile, and H. pylori. These all conditions give metronidazole. Remember the mnemonic; it's going to save you a lot of time. Get gap. All right. Then we have doxy. Okay, what conditions do we give doxy?
Doxy when there is
When there is
Lyme
sexually
disease.
transmitted
UTI,
disease.
yeah,
Chlamydia.
complicated
Chlamydial.
UTI
Chlam-
with
Chlamydial infection.
Chlamydial
yes,
infection, yeah.
What else?
Doxy
Lyme
also given
disease,
for the
Borrelia.
prophylaxis of Neisseria or Neisseria treatment.
Chlamydia as well, right?
in acne also. Acne, this if there is a
Acne, very good.
yes.
What is the main adverse effect for tetracyclines? Main.
It discoloration of the teeth. Teeth yellowish. Yes.
The other is photosensitivity. Remember that.
Photosensitivity also, yes.
All right. Okay, remember that. Okay, what is fluconazole? We know fluconazole. What is azithromycin used in?
This is macrolide, azithromycin. Also is giving in treatment of H. pylori. Sometimes azithromycin, and also cover the gram positive,
Yeah.
covering and this upper respiratory tract infection also azithromycin. Then
Yeah. Okay. So you're right. All right. Next question. LP reveals elevated opening pressure. Idiopathic ICH is diagnosed. All right. Weight loss is advised in the patient is prescribed acetazolamide. Okay. Which of the following changes are most likely to occur in the patient over the next several days due to the medication? What does acetazolamide do? What is the mechanism of action for acetazolamide?
in proximal convoluted tubules, it stops the
Bicarb reabsorption.
yes.
It inhibits the bicarb reabsorption at the proximal convoluted tubules. And it causes the acidosis. So
PCO will be low. What do you think? Because we are stop prescribe acid therapy. Total calcium, urine potassium, urine pH.
Mhm.
Okay, I made it
I
easier.
think it's C.
Oh, still can't figure out.
It's a carbonic anhydrase inhibitor decreasing your bicarb reabsorption, so it'll increase your urine pH, I think.
Yeah, and causes mild metabolic acidosis.
for partial pressure, carbon dioxide should be decreased because bicarb are low in the body. Bicarb low, so it will not be converted to CO2. CO2 should be decreased.
There's only one option where urine pH is increased, so I was thinking of C only with that.
Urine
Yes.
pH
Yes.
is increased. Yes, yes,
Exactly.
it's going
It's
in
more
this
alkaline, it's
favor of,
increased.
in the favor of, because the PCO2, PaCO2 also decreased, and the urine pH will be increased.
Increase, yeah.
Um,
Only this, yeah.
calcium will
C.
not be affected. Yes, calcium will not be
C
affected.
is
And the urine potassium will be
decrease and pH will increase.
yes,
C, I
it
think so. C.
will be C.
So why
Good
did we not think
job.
of B as well?
So we know that acetazolamide inhibits carbonic anhydrase in the proximal tubules of the kidneys, and that is why it prevents bicarbonate reabsorption, right? And because of that, it causes an increase in the urinary pH, making the urine more alkaline. So she was right. There's only one option. Use your brain. Furthermore, other thing I like to tell you that total serum calcium is that it has no change, all right? It does not affect the calcium. So no effect on calcium, urine pH is increased, we know. Oh, it was wrong. What? What happened? Why was it
Yeah,
wrong? Oh,
I think of B.
you
It
will
was
not
also
tell me it
increased
was
in the B.
Urine pH is
In B
increased,
also,
yeah.
It
B
increases
also had
secretion
increase.
of sodium and then
Total
decreases
calcium is
serum
decreased,
calcium.
yeah. That's
Serum
why.
calcium
And
also
potassium
so I
is
said that it
increased.
does. So the urine potassium, you guys did not tell me that. All right.
urine potassium.
Urine potassium is increased, so it will decrease in serum. So serum calcium will be increased because is serum calcium will be decreased because there's also increased in excretion of sodium and bicarbonate, potassium, and water. So
So
in turn, it will decrease in serum.
yeah,
So I
don't
think
go
that's what we missed it.
on serum calcium because serum calcium is fluctuable. Overall, it does not have an effect. Over here, it's just a misleading point over here. Serum calcium, no effect. Most of the times, it does not have effect. Even clinically, it does not have an effect on serum calcium. It does not decrease significantly. But the point is that the urine pH is increasing, right? We know about that, and the urine potassium is also going to
Also
increase. So
increased.
those two things are going to happen, which I want you to take away from here. And if you kind of see over here that increased distal reabsorption of sodium, it will stimulate the potassium excretion, leading to increased urinary potassium, and it will have mild hypokalemia as well. All right. So you should
And
be
decrease in calcium, yeah.
yeah. So again, increase in urinary pH, mild metabolic acidosis with compensatory respiratory alkalosis, mild hypokalemia, and mild hypocalcemia. So see, it's usually mild. We usually don't figure, we don't for calcium, we don't. It's not a big of a problem, unless it's too significant. But urine potassium is going to be increased, and urine pH is going to be increased. It's going to make it more alkaline. All right. Last question for today. The patient's treatment regimen includes a drug that is structurally unrelated to nucleosides and is not phosphorylated intracellularly. The drug acts within the cytoplasm of infected cells to inhibit the synthesis of viral DNA from the RNA template. Which of the following agents was most likely used in the patient? The patient had pneumocystitis pneumonia. And all right, no evidence of resistance. Okay, what is the drug that uses this MOA?
Patient is HIV positive, then DNA most of the time, then go with the NRTI. It's what is already.
It is the reverse transcriptase inhibitor.
Yes.
It is inhibiting the synthesis of DNA from RNA template. And the
I
reverse
think
transcriptase inhibitor is the zidovudine.
Zidovudine is
Zidovudine.
a weak nucleoside, yes, zidovudine.
Yeah.
It will be nevirapine.
Zidovudine is a weak nucleoside.
Nevirapine is a reverse transcriptase
Yes.
inhibitor.
Yeah.
Which one is the?
You sure?
Zidovudine is the weak, yes, this is the answer.
But zidovudine is an NRTI. It requires phosphorylation.
I'm not sure
And
which one.
then
Wait,
I think zidovudine is the.
listen, guys, listen.
D.
Hold. Ziodivudine is a
D.
nucleoside analog. Over here, what is it written? Unrelated to nucleosides. How can it be ziodivudine?
Then
I
Okay.
think it's C. Nevirapine.
Why not ritonavir?
Ritonavir.
It's a protease inhibitor.
Yeah, it's
Yeah,
a
it
protein
is.
inhibitor. Very good. Why not enfuritide?
It's an
It's a
integrase.
fusion inhibitor too.
Fusion, yes.
Yes.
Fusion
Very
inhibitor.
good. Why not emtricitabine?
It's like
It
tenofovir.
requires phosphorylation as well.
Yeah.
It does the same thing
Very
as
good.
globulin. So
So
nevirapine.
nevirapine.
All right, got it. So make sure that you understand what drugs are what. I told you that diadividine is a nucleoside analog. Let me see if I was right or wrong. Yeah. So again, diadividine, emtricitabine are NRTIs, and they should be converted into their active form before they can be converted pharmacologically. Plus, they're also nucleoside analogs. Over here, it's kind of mentioned that they're not nucleoside analogs unrelated to nucleosides. So try to read through the question. Each and everything is very important over here. So why wasn't it emtricitabine? It was because that it was an NRTI and it requires phosphorylation, and fubertide is a fusion inhibitor. It acts on the vital entry, not on the reverse transcription that was mentioned over here. And then ritonavir is a protease inhibitor. And diodividine, again, it's also an NRTI and it requires phosphorylation of nucleoside analog. The only drug over here is nevirapine. It is an NNRTI. It binds directly to reverse transcriptase, and it does not require phosphorylation to be active. It acts within the cytoplasm also. So, yeah. All right. So it's within the cytoplasm also. All right. Okay. So we are done for today, guys. If you have any questions, let me know. Ask me. And then I think that you guys have a class or not. A lot of there. All right. Okay. Yeah. Good job, guys. Okay. All right. No questions? No? Okay. All right, guys, wait over here. Dr. Moaz is going to join you within a minute, and then he'll take the class from here. I will see you guys tomorrow. Happy learning.
Thank you, ma'am.
All
Thank
right.
you.
Okay, bye, guys.